Next up, we have Alex Fix and Dr. Lavanya. Alex is the PROS director for the AAP, stands for Pediatric Research in Office Settings. He's going to talk about that. I've had the pleasure of working with Alex and PROS with many of you practices that have participated in studies. I've been involved with grabbing and exporting data and working with many of you. So I'm going to turn it over to Alex, who's going to talk about PROS, and Dr. Lavanya, who's participating PROS practice, has participated in some studies. We'll talk too. Thank you.
All right. Well, thanks everyone. Can you hear me? Awesome. Well, it's great to have you here this morning, and I think one of the most exciting things we can do is come back and share results with you from the great projects that you've contributed to, and that's what today's talk is about. And some of the themes that we'll address will build on what Dr. Diazio had already mentioned. We'll talk a lot about data. I have some, in the spirit of healthy debate, I have some results that sort of speak to some of the themes that Dr. Diazio mentioned from the Frameworks Institute work around vaccination. And actually, we had some different results if you think about texting families the messages as opposed to individual conversations or public health messaging. So I'll mention that. And we'll really try to have a good time with all of this. And it's really my pleasure to have Dr. Hiro Lavanya with me for this today. All right, so what will we focus on? How PCC and AAP PROS are partnering on current studies, why that participation is valuable, and Hiro will really speak to that, and talk a little bit about opportunities to participate in PROS research. So why is a research guy who works with the AAP but also works at a university here at the PCC meeting? The reason goes back to 1986. PROS's groundbreaking origins really said that we don't do a good job of bringing research to practice and making a difference to the care we provide if we have people in academic medical centers doing research in isolation and pediatricians and nurse practitioners and their staff working in practice separately. So the fundamental principle of PROS is to bring together the wisdom of practitioners in the office with the expertise and resources that researchers have to come up with studies that really do make a difference. So with that in mind, I want to share a little bit about what we found just over the last year in terms of some results. So there are about 98 practices in current PROS studies. We've had almost 500 in the last 15 years or so. There are 5 studies ongoing. You can see we have much of the country represented. And PCC is an important that 30 PCC practices are currently in PROS studies. You can see the distribution, which I think matches the distribution of where PCC clients are, but I'll double check that with Tim. And I just wanted to really thank you first for that participation. So now we have the fun part. We get to talk about some different studies we've been involved in and what we've been learning. So the first one is just a secondary data project. So we're taking data from PCC practices and looking at what's happening. This also involves some community health centers around the country, practices that use Office Practicum and other EHR, and some health systems. In total, we have about 1,000 pediatric practices involved. And so how are people using telehealth? Here are so the objective of the study is to describe the evolving use of telemedicine for problem-based visits in primary care for children across 6 domains on a national scale. This is how people are using telemedicine. Behavioral health concerns, respiratory concerns, endocrine concerns, infectious disease, derm, and digestive health are the top 6 conditions. And that's based on almost 14 million visits between 2019 and 2023. But how telehealth is being used is changing. Back in 2020, during the pandemic, behavioral health was such a leading concern. That was just a huge proportion of telehealth, followed by derm and then endocrine, which was weight checks and other measures of wellness that way. But by 2024, that shifted. We're really monitoring weight and taking account of Child well-being in terms of lifestyle and growth is at the top of the list. Behavioral health is second, so still a major force. And then issues like digestive health are way up there too. And interestingly enough, it's not digestive health like let's take care of your constipation. The number one conditions that we see in the digestive health category are things like functional abdominal pain, where people are checking in and treating those hard to reach conditions via telehealth. And as we looked at this, we asked the question, are these telehealth visits just substituting for in-person visits, or are they really adding capacity? And what we found is that telehealth is being used around the country to add capacity for those conditions that are so hard to treat, like obesity, like behavioral health problems, and like functional disorders. Another finding from that study looked at antibiotic management of respiratory tract infections. And so what was known before the pandemic is that there were a bunch of companies that were doing direct-to-consumer telehealth. And when those companies interacted with patients and families, they were giving kids too many antibiotics. They were much more likely to prescribe antibiotics in a non-guideline concordant way. And so what this study asks is, what about when primary care pediatricians in the medical home do the same thing? Is telehealth just a way to give out tons of antibiotics? And it turns out that guideline concordant antibiotic management when pediatricians do telehealth from primary care is exactly the same as it would be in in-person visits. And not only that, perhaps because of the triage process, but behavioral health diagnoses, bacterial diagnoses are much less likely, and antibiotic prescription is also less likely in those telehealth visits. And you may wonder, but then if people are using telehealth, are people coming back much more often or having complications? There was no difference in the need to change antibiotics after telehealth visits compared to in-person visits, and there was no increase in the need for follow-up visits or other kind of health interventions in those kids. So telehealth really proves to be a safe way to manage antibiotics for respiratory tract infections. So this next one is one that touches on some of the messaging that Dr. Diazio was talking about. And just because I think it's important to acknowledge the times we're living in, these are results from a study that was canceled by NIH because it addressed vaccine hesitancy. And so fortunately, we were able to complete the first year of the study. We're analyzing the main results. But what I wanted to share is the results we had from talking to families about what messages most resonated with them when we texted them through text messages and how they wanted us to approach that. I think some of the lessons the questions were specific to vaccination, but I think some of the lessons speak to broader messaging strategies that might be applicable to texting. So we developed these messages based on behavioral science principles. We involved 4 practices. 18 parents were involved. We included English and Spanish speakers. Parents graded messages based on how motivating they felt the messages were, and they were iteratively refined, with the ones with lower grades discarded. And an abstract about this project was presented at the Pediatric Academic Society's meeting this year. So this is what we found. What were the elements to include? The practice's name and phone number so people know it's not spam. A link to schedule an appointment so people can take the minimum number of steps possible to be engaged and connect and get that vaccine. Include the child's name unless there's more than one name, and then you can just say your children. And that's a way of personalizing it and, again, making a specific connection and also not confusing people who might have multiple kids. What about the themes in those messages that matters? Give planning prompts like, you're due in a week. Come, schedule the visit. Talk about not missing out. That message actually resonated. This idea that if you don't schedule now, maybe the supply will run out or you could get sick. You don't want to miss out on this chance at prevention. So the issue of how vaccines help a body get ready to challenge a virus, again, not the military metaphor, but this idea of challenging the virus. And also there is a bit of a community social good element that families really responded to. Being healthier when everyone is vaccinated. So what are some of the themes that didn't resonate? Interestingly enough, because frameworks found that the software metaphor was helpful in terms of updating, families did not like that message as an individual text message strategy. They didn't want to hear about low vaccine supply. They felt like missing out was much better. And even though the idea of being healthier when everyone is vaccinated was really positively received, the idea of just going out and saying we want to protect the community, that was a little too diffuse and a little too about everyone. So some things that might be applicable and that you can think about using. Another set of big results that came out this year and benefited from recruitment and PROS practices, including practices that use PCC, are from the NIH RECOVER initiative, which stands for Researching COVID to Enhance Recovery. And the big question that that study asks is, what is long COVID in children? There was lots of talk about long COVID in adults and different aspects of it, but really no one had any idea what it looks like in children. And this study provided that answer. So in a series of 2 publications that I'll summarize on the next 2 slides, a picture of what long COVID is all about came out. And I encourage you to think about it, and I've started doing it in my own primary care practice, is when you have kids who have non-specific mixes of symptoms, long COVID actually has a lot of explanatory power with so many kids exposed as a potential source of those problems. So here we go. What did they find? All right. For infants and toddlers, what did long COVID look like compared to kids who didn't have it? More likely to have trouble sleeping, fussiness, poor appetite, congestion, dry cough, and a wet cough. Preschool age kids were a little bit different, still the dry cough. Daytime tiredness and sleepiness or low energy was especially common. Now we're going to move on to the higher age groups, and I apologize for the small font, but I'll tell you the highlights. School age kids uniquely, fears, school refusal, palpitations, and itchy skin and rashes were much more common. In adolescents alone, panic attacks. Similar to one of the things we heard a lot in adults, loss or differences in smell, and congestion, chronic congestion. And common to both the 6 to 11-year-olds and the 12 to 17-year-olds were a number of additional symptoms. Trouble sleeping, tired after walking, low appetite, anxiety and depression, fear of crowds or agoraphobia, dizziness, and stomach aches and muscle aches. So as you start to see these complaints, which admittedly are exceedingly common and show up in different ways, it just is another element to add to the differential to think about long COVID in that context and how it may or may not be contributing. Next, I'd like to talk a little bit about the STOP HPV trial that I've mentioned when I presented in the past, and we have some new results related to that. So that study was really about how can we as pediatricians best prevent cancer. We know from results of that study that when pediatricians were trained in a 1-hour set of 3 modules, that they were like about 20 minutes each, maybe even less, that they were better able to communicate and responded very positively and enjoyed the training. And not only that, but missed opportunities for vaccination when kids came to the office and were due dropped dramatically for initiation when the pediatrician referral is especially important. And now we're working with Title V programs from different states to disseminate this. So we've partnered with Michigan and Alabama, and they're distributing the modules to a range of health professionals. Trainings that were developed in PROS with this group and originally developed for pediatric clinicians are now being shared much more broadly. So this next slide shows the range of different stakeholders with whom they've been shared. Michigan Department of Health and Human Services, the Child and Adolescent Health Centers, the state immunization programs, local maternal and child health programs, the American Cancer Society, public health nurses, vaccine champions. And in Alabama was really interesting. They added a partnership with dentists. It turns out a lot of dentists don't regularly talk about HPV in the context of HPV disease, but the fastest growing cancer that's HPV related is oral cancer, and that suffering is particularly relevant to dental care. And so we engage the dentists. So the Alabama Board of Dental Examiners disseminated it to its members, the Alabama Department of Public Health and Cancer Control, the Alabama Breast and Cervical Cancer Early Detection Program, county health departments, the Board of Nursing, Comprehensive Cancer Center at UAB, University of Alabama at Birmingham, the American Cancer Society, a Maternal and Child Health Leadership Group, and the AAP chapters. So it just sort of speaks to the fact that this information originally generated with practices is now having much more reach. And we're submitting a grant now that will build on the Stop HPV model to do the same thing for influenza vaccine, which is suffering from dramatically dropping rates in the context of rising vaccine hesitancy and misinformation. So we're adapting that information for influenza, and we'll test 4 best practice office system changes. That grant is being submitted this year, so we may be recruiting for it when I'm here, hopefully next year. And in an ongoing way, we have the comparative effectiveness through collaborative electronic reporting consortium. So this is a way that practices can participate in research without clinicians having to do much of anything except complete a data use agreement. So I encourage all of you who haven't had a chance to participate in PROS to think about doing this and applying. But the results can be really helpful. This is one study that was led by Stan Grabczewski, an investigator out of CHOP, that asked, how do allergic conditions unfold in childhood? Lots of anecdotes, but this looks at records of millions of kids to see how it happens. Atopic derm is usually the first symptom, peaking at 4 months, and about 10% of kids affected. IgA-mediated food allergy, 13 months. Asthma, 13 months, it starts to show up and peak. Allergic rhinitis for kids 2. And then eosinophilic esophagitis, much less common, but still present and peaking around 3 years of age. So we know this because of the data supplied by PCC and others that allows us to look at these patterns. So now it's my pleasure to turn things over to Dr. Lavanya, who'll talk a little bit about her extensive experience working with PROS. And then I'll wrap up by talking a little bit more about future directions. Thanks, everyone.
All right. Can everyone hear me? All right. So I'm Hira Lavanya. I'm a pediatrician in Georgia, 2-provider practice. And I joined AAP PROS several years ago, and the reason I did was because in medical school, I did a research study where I was looking at token economy and seeing how, if I could use token economy to decrease sugar intake in children. And as a scared little medical student who'd never been on the debate team, I had to go in front of the IRB twice. And if you've never done that, I highly recommend a beta blocker. But yeah, it's scary. They're very intimidating, not pediatric friendly at all. So I decided that joining AAP PROS was great because I didn't have to go in front of the IRB and I didn't have to write grants. So I've been working on many projects with them, and this year I ended up being a part of PROS as a Georgia representative. And it's amazing what they do. So before someone has a study, they talk to a smaller group of us, and we see if it's going to be viable in a small pediatric office or even a large pediatric office. And then they go back, they adjust the studies, and then they come to the full board. We talk about it some more and vote. And once we vote, we decide if it's going to work or not. And if it does, then the study goes for grant funding. Once the study is approved, the PROS team starts recruiting practices, and that's where many of you come in. So you're not left to figure things out. Like, they hold your hand the entire way. None of the studies that I've worked on have I ever felt like, oh, this is too much for me. So And the amount of time commitment you want to do really depends on you. So there are some studies where, like the telemedicine study, I think I just signed some paperwork and let the data flow through PCC, and that was it. So it was HIPAA safe, stress-free, and I didn't really have to do much. The Stop HPV study, that was amazing. So we collected baseline vaccination rates for HPV, and then the providers and nursing staff, we had to complete these like short modules over a course of a few months. And so we looked at our rates, and before the study, we had about 30 to 40% HPV vaccination rates in our practice. And then after the study, we jumped up to about 60 to 70%. So we could see that real change in our dashboard every month. It was just amazing. Right now, I'm participating in the Heart Plus study, so we're in the early phase of collecting data. And the study has two major goals. So first, we're trying to identify teens at risk of depression or suicide and help them develop their own personalized digital safety plan. We're going to provide access to what's called a Bright app, and then this app is going to be like a teen focus, designed to help them build coping skills for those intense moments when emotions are high and they need something to ground them. Data collection takes me about 5 minutes a day, but the potential to save lives is powerful. As far as study requirements varies, but you can get offered perks like Mach 2 or 4 credit, and sometimes you get monetary compensation. So my daughter did the long COVID study, and she's still getting paid for some of it, so she's excited about that. So sometimes the parents don't get paid, sometimes the children get paid, sometimes it's vice versa. So it really makes it worthwhile for the patients as well. But my main takeaway is that PROS makes it possible for pediatricians like us to participate in meaningful research without flipping our schedules upside down. You can make a difference one study at a time or even one click at a time. And if a 2-provider practice can do it, all of you can do it. So if you're even a little bit curious about PROS, come talk to one of us. We'd love to have you be a part of this work. Thank you.
Thanks so much to Dr. Lavanya for giving that sort of firsthand experience. And I'll tell you a little bit more about how you can share your information with us, and then we'll also be at a table over lunch. Oops. Let's see. Let me click on reload. Should I just double click it and open it back up? Oh, okay. Then you know what? I'm just going to go with it.
Go ahead.
Fair enough.
I'll work it out.
Here we go. All right, but can I advance the slides?
Yeah.
Not so much. Well, I'll tell you a little bit about the studies that are upcoming, because I kind of know about them. All right, so the first one that I wanted to, here we go. Multiple studies are in the pipeline. There you have it. Thank you to our expert tech team. This one is really cool. So this point of advocacy, we have a number of studies that have fundable scores where we're waiting for their approval. This is one of them. I hope that it will start as early as this fall. So one of the big things that we all struggle with as pediatricians, I think, is when families come to us and start to mention that their kids aren't sleeping well. And we have a sort of set of guidance that we can sometimes bring. And we also struggle a lot with families and kids, teens in particular, who are using social media all the time in a way that's disruptive to their sleep and other aspects of their life, including their academic success. This study is really a marriage of those two. What we aim to do with this study, that will be enrolling a number of pediatricians and pediatric offices, is to adapt. The AAP created a tool to use social media in general, to guide parents in using social media. We want to make it so that it can be used in a targeted way by pediatricians working with families to address sleep. So this study was submitted to the National Institute of Mental Health. It has a fundable score. It's working its way through the process, and we're hoping to bring it to you soon, really to address this sort of profoundly difficult and common issue of how do we get kids to get off media and sleep better. Our next study. This is by a study that's being led by two national leaders in the field of firearm research and health communication. Patrick Carter, who's at the University of Michigan in their Firearm Center, and Ken Resnikow, who's really probably the international leader in motivational interviewing. So this study will ask the question, can we better motivate families to safely secure their firearms at home in the current environment? Now, what the literature suggests is that even in states where people are very attached to their firearms, and for individuals who are, nobody wants to see kids shot by guns that are unsecured. And so what this is a strategy to do is to help us in pediatric offices better get gun locks into families' hands and have them use it. Again, it's received a potentially fundable score by NIH. We're waiting to see what happens. Another study that's in development, actually, that's going to be co-led by Sean O'Leary, who no plant, but Christoph mentioned this morning, and Doug Opel, who's another investigator. And that's going to look at communication strategies around early childhood vaccination that are increasingly important as we see rates dropping. So that will be submitted soon and will be if it's funded, a study that will involve quite a large number of pediatricians. And then finally, there's a program called Greenlight that some of you may have encountered. They've been working on developing it for, I'd say, more than a decade. And they had a publication that came out this year that showed using a set of strategies that primarily involve texting families at home with obesity-related information. They were able to impressessively prevent obesity among kids at age 2 years compared to those who didn't participate. There have been many, many studies have tried and very, very few that have succeeded. And the ones that have succeeded haven't been grounded in an intervention like this that's as scalable. They've been more labor intensive. And so that's a grant that we're developing and we look forward to submitting in the next year. And that also will be open to involving many practices. And so I think something that we can all aspire to prevent obesity better, and also to test how and in what context it really works in primary care offices, just because one study is one study and it's amazing, but we need this to work for all children. So I'll flip to the last slide. We're open for questions. And before we're done, this is a safe QR code. If you could please scan this QR code. The magic of PROS is that we take ideas that come from people like you and find investigators and projects that are a fit and fundable strategies so that we can actually test them. And so this asks for your name, your email, and any ideas you might have for studies. And it also lets us know who you are so that we can reach out as opportunities come up and tell you about different projects. So we want to thank all of our funders, the AAP, NIH, our investigator partners, the HRSA, the Health Research Service Administration Maternal and Child Health Bureau, PCORI, the Agency for Research, Healthcare Research and Quality, and most importantly, for you and your practices and the families within. And so I don't know what our schedule is in terms of opportunity for questions, but
Got about 10 minutes for the next session starts.
oh, good. All right. So If anybody has questions, we're open to them, and we'll also be here afterwards and can talk to you one-on-one, and then I'll be at a table downstairs over lunch and look forward to seeing you there. So raise your hands, let's jump in, and feel free to direct questions at Dr. Lavagna, who knows much more about the experience of doing them, or to me. Here, please.
My question is, so your practice of 2, for larger practices, maybe to book
Right.
you, do you have to have, I don't want to say buy-in, because everybody agrees this is good, but do you have to have participation of all of the practice members in order to participate?
All right, so the question was, does everybody in your practice need to participate in order to join a study? So the answer is no. We want pediatricians who are interested in participating to join, even if there's someone in the practice who isn't right for a particular study. And the EHR stuff doesn't involve anyone having to do much, and so it's very easy for the practice to participate as a whole.
Thank you.
Other questions? Hi.
Hi, do you get to choose which studies you participate in, or is it more of an assignment?
So the question is, do you get to choose, or is it more of an assignment? Do you want to talk about?
You get to choose which study you want to be in. So sometimes they'll email you and say, hey, do you want to be in this study? And you can decline it, but they will give you a little information about what the study is and how much work it'll entail and all that. So, but if you don't have time, you can just say, not this time around.
Yeah, so being part of PROS gives you the opportunity to participate, not the obligation to participate. Anyone else? Well, thanks. Oh, back there. Yep.
Okay, let's talk. There you go.
All right, awesome. Anyone else? So if you haven't yet, please scan the QR code. Please visit us over lunch. We have swag. And thanks so much for taking a part of your day to share with us, and for those of you who've participated.
Thank you, Dr.